Good morning and welcome to our UBC Learning Circle, Life Stage Transitions and Hormonal Change, an Indigenous perspective on menopause with Dr. Sarah Connors. Today's conversation is presented with partnership with the Center for Excellence in Indigenous Health, and we'd like to thank the First Nations Health Authority for generously funding the UBC Learning Circle and allowing us to have these conversations. Before we formally begin, I'd like to acknowledge with respect and gratitude that I'm joining you from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Feel free to introduce yourself and the nation you're calling in from in the chat box. And for those of you who don't know me, my name is Serene Squawkin. I am the Learning Circle Manager. I am Syilx Okanagan on my mother's side and Hickory, Apache, and Belgian Settler on my father's side. I will be the moderator for today's discussion, and joining us working behind the scenes is Cynthia and Kira, and they will be interacting with everyone in the chat. Finally, before we get into today's discussion, I will provide a gentle heads up that the topics covered may be sensitive or emotionally triggering. So please make sure you're looking after yourself and if at any point in time you need to talk to an elder, friend, counselor, family member, don't hesitate to do so. Now I'll turn it over to Dr. Sarah Connors to introduce herself.
Sego, everyone. As Serene was so nice to say, my given name is well, it's not doctor, but it's Sarah, Sarah Connors, and my spirit name from one of my elders is I usually say both. So initially given to me in Anishinaabe, so that's Wabizekwe. And then I myself on my father's side am Mohawk. So in Mohawk, that is Onasagan and that roughly translates to White Swan Woman. So I walk with both. For anyone who was able to join us when I was here previously, I mentioned how I walk in both shoes, both worlds, having Ukrainian and Irish, and as well as Mohawk in my direct ancestry. So walking with both sides there. And I'm actually in Ontario, so it's technically the afternoon for me. So if you happen to hear me say good afternoon, that's because it's already afternoon here. Um, and yeah, that's so I work here in Southern Ontario in Waterloo, Kitchener area, and then I also usually travel up to Muskoka, Simcoe, Muskoka, Georgian Bay area as well. I grew up there, not too far from Rema in Aurelia. And but so I still consider kind of both areas my homes, and I tend to travel back and forth in terms of working with our Indigenous communities and providing care through my practice, Saratoga Family Naturopathic, and then also the various opportunities like this that I am so glad I get to do to help not only support our people but support all the patients I'm fortunate to work with and support. From my littlest littles, I've got a two week old patient right now, who was just born 2 weeks ago, and then my oldest patient being currently 87. So I do have the full lifespan that I'm so grateful that I get to work with. So I know we're all here today, and I was told quite a few of us here today, which is great, to talk about this big transition that happens for so many of us, which from an English word, we talk about it in terms of perimenopause, menopause, but what does it actually mean for us as Indigenous people who are walking through this, not only this life, but then also this big life transition? And we're only just really getting to the part where we're actually having better conversations about this, whereas before, like so many things to do with our reproductive life, especially since colonization, we've been told to be hush hush about it. But that's not how we did things. Not before colonization, not before the last 250 years. It was a case of each generation teaching the next generation, right? So we'll talk a little bit about, moon time, just because that's relevant. in terms of that transition period, right? So when I say moon time, I mean our period. If you haven't happened to hear the term moon time before, I kind of use them interchangeably depending on who I'm talking to. And then you'll also hear other terms as well that because there are phrases essentially that different peoples, and when I say peoples, I mean Indigenous peoples, have referred to that transition piece. So I'll use again perimenopause, menopause, and different phraseology in a little bit interchangeably as well. And of course, questions are very welcome. I think last time we tended to wait a little bit more towards the end, because some of the material you'll ask a question and it's like, two or three more slides from now, you're going to see exactly what we're talking about. So I might say that. Just so that we can keep things moving and leave some time towards the end for any sort of questions and things like that. So hopefully everybody's comfortable. As one of my teachers likes to say, pull up a cup of tea. This is a time for us to sit together as however we identify. Whether we used to say with Moon Lodge, we welcome all the women in, right? And so now we say all the people where that is relevantly appropriate and relevant too. So I will say, I will try and use people first language. If you do hear me saying women a little bit more, that's just from habit. And it's certainly not with any intention to leave anybody out of the conversation. And then I also really try hard to say people first language and then also in addition to that, I might say those of us who carry a uterus or those of us who carry what's we currently phrase as female reproductive systems. Okay. All right. Wonderful. So I'm just going to share my screen here. All right, so the first couple slides I'll move a little quickly here since we covered this in a little bit more detail the last time I was here. So for those of you who weren't able to join us the last time I was here with the Learning Center, there's the two-eyed seeing presentation goes into this a little bit more in depth, but just to give us a place to kind of start from, I like to compare when we're talking about from my perspective, my naturopathic practice. I often talk about the similarities between Indigenous health and wellness and perspectives on health and wellness, and how we look at it from a naturopathic perspective as well. So many of you know we're talking about the person as a whole. We often use the wheel or the medicine wheel as an example of this as well. And so we're talking about physical, mental, emotional, and spiritual wellness, making us whole as a whole person, right? Using the gifts that Mother Earth has given us to heal, and also giving the body some time to actually heal without us intervening too heavily, right? So very, very similar naturopathic philosophies, principles in terms of approaches to health. It's treating the whole person, talking from a physical, mental, emotional, and spiritual perspective. We'll sometimes use the terminology, the healing power of nature, which is very, very similar to our concept and understanding of using the gifts that Mother Earth has given us, that Creator has given us addressing the underlying cause of illness. So not just looking at the symptoms, but looking at the underlying root of what's going on here. So when we only look at the symptoms, often we're not actually dealing with the underlying problem, right? So similar sort of thing in terms of how we tend to approach health and wellness as well. And of course, prevention. So having prevention as the main focus from a naturopathic perspective. So not just leaving things and saying, oh, we'll wait and see. Sometimes it's valid to wait and see, but it's also that case of, well, is there something we can do now to prevent or reduce the likelihood of this becoming something more significant later, right? And not just waiting for something to develop into a really serious health condition. If we can see that there's some signs there that this could come later down the road, then let's do something about it now to either completely avoid it or reduce the chances of it happening. Okay. So it's just quick little chart there. Again, kind of showing them side by side to show the similarities and where that overlap is. Okay. So ultimately, what I end up talking to a lot of our Indigenous communities about is naturopathic medicine as a bridge. So what I mean by that is that I feel, and this is how I practice in my practice, is that the naturopathic approach very much complements what many of our traditional healers are doing in their work. And it's not to say that it's a replacement by any stretch of the imagination, but we learn about the herbs, we learn about nutrition, we learn about this fuller, holistic approach to health and wellness. And then we also learn about what I overall term the hard sciences. So biochemistry, physiology, anatomy, a lot of the research-based pieces of Western medicine. And so by bringing those two together, then it's really pulling from all the positive, ideally all the positive places where we can bring the two together and really have an ultimately overall beneficial approach between utilizing our traditional medicines and what we know to be traditional medicines, and also the benefits of the Western medical approach or the Western conventional medical approach, depending on how you frame it. All right. So just a little bit of kind of background there in terms of how we tend to approach things from a naturopathic perspective and integrating that into how we do things from a naturopathic perspective. So in terms of why are we talking about this? Why does it even matter to talk about perimenopause, menopause, any of these? Why does this topic matter, really? Well, about half the world goes through this transition if we get to that age, right? That's a lot of people. If about half the world is experiencing this thing, is it not worth talking about? That's been my argument for a very long time. And so when I hear people say, well, my doctor doesn't want to talk about it, my nurse practitioner doesn't want to talk about it, well, you're just supposed to go through it. You're suffering a little bit. What does that even mean? Right? It's it's so why I say all that is, and I'm seeing a lot of reactions, so thank you for is exactly what's happening in the reactions right now, is because so many of us are feeling left out in the cold, and that we're not getting the information, we're not getting the support, we're not getting the things that we need, right? And that's exactly what this 2005 study in Nova Scotia found, was that when they talked to their focus groups, which were mostly Mi'kmaq women, they found that they knew very little, if anything, about the mechanics of menopause. But they understood that there was something on there, right? They understood there's holistic change, there's important changes happening, right? And of course, from a that colonized point of view, that Western point of view where aging is a downfall, right? There's so much discussion about as we get older, we're falling apart. As we get older, oh well, we just generally fall apart until we die, right? Is that kind of that story that we hear over and over again. But what we were always taught was that our elders were to be revered, that becoming a grandmother, an auntie, any of those roles where you were an elder woman or an elder person within our communities was we looked to you with respect because you had wisdom, because you had life experience, because you had teachings, right? You had important things to pass on to that next generation, right? That's how we've always looked at our elders, right? And it's gotten a little muddy, understandably, with the integration of Western colonial ways of thinking and indigenous whole systems and whole world views of thinking. But that doesn't mean that we can't work on it, work together as a collective to bring those healthier teachings, which really talk to me. I often talk about this stage of life as powerful, as empowering, as stepping into that version of your life that you get to focus a little bit more on you, right? Not to say you don't still have roles and responsibilities and things like that, but it's really a much different conversation than what other people are having, especially from that, what I frame as the Western colonial view of things, right? So it's really about changing relationships, a time of rest, and getting a chance to focus on ourselves, and freedom, right? As we're past that point of childbearing. And so hopefully, I know there are many grandparents that are stepping in either in some capacity or sometimes in much larger capacities to help with that child raising role still. But hopefully, you get a little bit more freedom and a little bit more time to explore your wants, your needs, and what does that mean for you, right? As an individual. And possibly collectively as well, in terms of your family, your community. What does that look like for you? So it's not a case of falling apart and being forgotten, is basically the point I'm trying to make there. So as I said, we've had generally, unfortunately, negative and fearful expectations about what menopause looks like, right? So it's a lot of discussions around, oh, well, you're falling apart. Oh, well, you're only so far away from returning home to the to Sky World, which again, we have a very different concept of that whole approach as well, compared to the Western views on death and dying. But point here being is that this could be a much more positive, basically. And then, of course, the other thing too is you don't need to suffer through it. This is the probably the biggest, if I was going to call anything a myth, it'd be this, that we have to suffer through it, that you have to put up with the hot flashes, that you have to put up with the night sweats, that you have to put up with all the other things that, for some women they experience it and for some they don't, right? Um, and the other unfortunate thing is that right now, because of, and I'll talk about that study in a little bit, one particular study that has driven the whole story on hormone replacement therapy for the last 10 plus years is like, actually, that particular study was flawed. And hormone replacement therapy is not the devil, which has been the story within the Western conventional community for quite some time, right? Not to say that, and it's like anything else, not every single medication, therapy approach is the right fit for every single person. But there's quite a few people that in the right dose and the right management and all those other kinds of things, they actually do very well with hormone replacement therapy. So again, we'll talk about that a little bit more as we go along. So for anyone this is actually a really great series if you're wanting to kind of dive more into understanding menopause and what's coming through, because it's essentially just a group of Indigenous women. Again, kind of that Moon Lodge concept where we're sitting around and talking to those who have gone through it, who are going through it. How did you talk about it, both now and before going through it? And you can, at least the last time I looked it up, you can pull it up on YouTube, Indigenous-centered menopause. So this is just a few pieces that I pulled from some of the episodes that I watched myself. And so with speaking with First Nations researchers and elders, there's no consistent word for menopause, at least when we're looking at Ojibwe and Oji-Cree. So it's commonly referred by a couple different phrases, is how it's often referred to. So that time when periods stopped. This one was an interesting one, which I still have to dig a little more into. Bit by the fox or coyote. I'm sure there's probably a longer story behind that I haven't learned yet. But and then of course grandmother doesn't visit anymore. So that one, I actually did have a chance to talk with one of my elders, and she's like, "Oh yeah, it's that whole connection with Grandmother Moon, right?" And so that conversation about when we do go through our moon time, it's that grandmother's visiting, right? Or Grandmother Moon is visiting, and she's there to support us and to get us through that period of time, right? And so when we say grandmother doesn't visit anymore, then that's we're talking about our moon time, our period no longer being there, which essentially is the hallmark of menopause, right? So it's a very interesting kind of definition from a medical standpoint because menopause is technically 12 months, right? And this is where a lot of people get a little confused about that whole process because it's like, well, doesn't it last years? It's like, well, technically that's the perimenopause, right? And so menopause is kind of this funny thing from a definition standpoint only, in the sense that when we're waiting for our moon time to stop, to finish, right? Is that's the menopause. So it's this case of where almost like if for those of you who have had babies, I sometimes equate it to this. So like when we're waiting for your baby to arrive, right? It's like this, okay, I'm gonna rush and like, okay, okay, okay. Oh, now I gotta wait. Okay, 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 and then now I gotta wait, right? So it's a little bit of that repeating itself to a certain extent, in the sense that we can miss a cycle, and then we can miss the next one, and then the next one, and then all of a sudden it's back again. It's like, I thought we were done with this. So it can, I frame it from that perspective to try and add some levity to the conversation. So I say, well, our body's playing tricks with us. Right? It's a little bit of the trickster energy when we're talking about it at that point. So it can do a lot of different things, and it's not identical. It's not the exact same experience from one woman to the or one person to the next. Um, it can look different. And then some, it's like they just sail right through. And it's like my period stopped one day, 12 months later. Yep, still haven't had it. I'm like, okay, then you're technically through menopause and into postmenopause now from a medical standpoint. So like I said, it's a strange thing to think about from a diagnostic or a definition standpoint, but that's essentially what's going on there. So this slide here is just talking a little bit of, these are some of the snippets from some of that focus group research that I was referencing earlier. And it's, again, just pointing out how for some they actually did get a chance to talk to their mother, to their auntie, to their grandmother, or great grandmother. They had someone to talk to about it, right? So then it wasn't a surprise for them. But then for others, it's like I didn't really have an opportunity. Like I never really knew what was coming, right? And so they just feel a little bit lost or a lot lost. And so these kinds of conversations are so important to have and to continue to have so that it's not a case of people getting and for the men too, like I know we're talking more about those of us who do live with the uterus, with ovaries, but for them too, because then they can understand what we're going through, right? So, in terms of what is normal, and like I was saying before, it's not identical from one person to the next, right? There's common symptoms, like some of the ones we talked about. And I think I did accidentally put hot flashes in twice, although I'm pretty sure some of my patients would say, nope, that's the right way to do it because that's the right emphasis on how they're experiencing their hot flashes. And then headaches or migraines. Sometimes this is one I'd say people are like, really? That's a potential symptom? Yeah, unfortunately. I've had a few patients where I've never had migraines in my life, and then boom. I'm like, yeah. I don't like to like it's just like I'm not trying to be a bad guy here. But those things can happen, right? Memory changes, feeling like your focus isn't quite the same as it has been in the past. Difficulty sleeping, some of that's related to the hot flashes and the night sweats. And then of course just temperature regulation issues in general. So obviously hot flashes and night sweats or hot it's another term that one of my patients likes to use, and I was going to use it and I forgot it now. But yeah, it's essentially that it's a hard yeah, you've for different people they have a different experience, and then of course how much that goes up and down depends as well. So again, that's not meant to be exhaustive by any means. Just kind of listing off the more common ones and the ones that we tend to see just a little bit more often. And this one, that's why I'm leaving it there for a second, is we don't have to live this way because this is the other thing that we've been told for. ever is that it's like, oh, well, it'll go away in a little bit. Just give it some time. So as long as you're not suffering horrendously, then we don't have to do anything about it. It'll just take care of itself, which is also the same thing we get told about our moon time, our period. If you have pain, it's like, oh, well, that's normal. There's a big difference between normal and common. And just because something is common does not make it normal enough to have to deal with it. Right. So I say that to all the people I work with going through their reproductive journey, whether we're talking about where you're starting from, we're somewhere in the middle, or we're somewhere closer to this stage of life. It's applicable across the board. So that is always my philosophy and my approach when I'm dealing with people. I don't accept that baloney story, and that's the PG version of that story. Um, so I just want to go back to moon time for a second. So that we're just all on the same page because this is another thing I tend to find is in working with people is there's still a lot of people that don't actually fully understand what their body's doing when it's going through their moon time. And so how could you expect yourself to understand or know what's going on the other side when it's starting to ramp down slash, for lack of a better framework, stop, right? So that's why I like to talk about moon time just briefly, right? Just so then you have a little bit and we have a common ground when we're talking about certain things. So, in terms of how we understand this is a sacred gift, right? We so often we talk about it, and I even had this experience recently with a doctor. He's like, "Oh, isn't it great that you only have it, two for 2 or 3 days?" And I was like, "Well, no, because it's not supposed to work that way. I'm just in a spot right now where this is what I have to do to support myself." And I won't get into too much about the fact that it was a male doctor and all those other things. But it's just the fact that it's not fully understood that it's actually when we're at our most powerful. And the other next one is now what we're talking about, perimenopause and menopause. This is actually a very powerful time of our life. Right? Where and in certain ceremonies and things like that, you're actually told either not to participate or the one thing I remember the very first time I had a grandmother explain to me, like, oh, if you're on your moon time, we need to put you over here. And I was like, what do you mean you need to put me over here? I was just very confused. She's like, you're at your most powerful right now. So she's like, we will like you can stay, that's fine. But we need to put you over here. And you're going to use your medicines and she she explained everything to me. And so that was their teachings, right? Where I was visiting is that because you're at your most powerful, you actually step away a little bit, right? And that's part of where some communities have moon lodge, right? You would go to the moon lodge while you were on your moon time, right? Because you're just so powerful at that particular point in time. So we know it's that heightened connection with Grandmother Moon, creation, and water, right? That is our sacred duty, that we carry the life waters and we care for the life waters, right? And it's a time to cleanse both emotionally, mentally, physically, and spiritually, right? I This is a an image I use a lot in a lot of different presentations just because I love it so much. It's just such um, a beautiful representation of Sky Woman and the circle of life, and understanding that we are connected all the way back through all of our lineages, right back to her, right back to Sky Woman. And that the fact that when you're that itty bitty little couple cells inside your mother, inside your grandmother. And it's one of the most like wonderfully confusing things in my mind, for people to kind of wrap their heads around, right? So you really understand there is that, especially the matrilineal lineage. Not to say that all our lineages aren't important, but it's just that that line it's been creating you all along. You're all the way back, right? So we talk about 7 generations back and 7 generations forward, right? So this is what we would call like straight from the textbook, 28-day cycle. Obviously, not everybody experiences a 28-day cycle. Not everyone's hormones peak and drop. But if this were to be, again, the textbook definition, where we just have a nice, simple place to start from, that's why I like to use this one. Because in theory, we have roughly 4 to 7 days, hopefully, of menses or moon time. So that's the very beginning there. At the bottom of the gut diagram, you see 0 to 7, right? So that's where we see the actual like blood, right? Again, if it's working the way it's supposed to. Then we start to see that endometrial lining start to rebuild in preparation for, in theory, a fetus, right? Or preparation for pregnancy, right? Because they need to nestle in there and have something to latch onto to start to create that placenta if there were to be a pregnancy. We're also seeing that estrogen's coming up, and then estrogen and progesterone kind of flop in terms of one's more dominant, the next one's more dominant. And then, of course, hopefully, ovulation in the middle there, approximately somewhere in the window of day 14-ish. And then again, everything's still building until there's no presence of an implanted embryo. So then there's all the triggers that happen to say, okay, yeah, no, we're good. And the whole thing starts all over again. Right? So we have estrogen being the dominant hormone in that first half of the cycle, or the follicular phase is the other thing we call it. It's helping to produce that healthy uterine lining and ensuring the maturation and release of that egg. And then that second half is generally progesterone dominant. And it's helping to maintain the uterine lining. So if we did have implantation of an embryo, then it's helping things to maintain until the placenta and some of these other changes that are meant to support the continued growth of that fetus takes over. And then the lining isn't quite as needed anymore. So it kind of takes a bit of a back seat, but it doesn't get shed usually quite the same unless we're talking about everything kind of starting all over again, right? So this is, and then of course, facilitating the balance of hormones in other organs is another job of estrogen does this as well, but progesterone a little bit more so. And so this is where sometimes the conversations about the thyroid start to enter in from our perspective. It doesn't always get missed, or sorry, it doesn't always get talked about and is often missed in conversations from a conventional perspective only. Then, of course, what we're talking about in reference to perimenopause and menopause is that we have that big estrogen decline. That's progesterone levels do decline as well, but it's mainly estrogen that's kind of driving that whole process. Usually we see this in our 40s and 50s. It can happen earlier in life, which obviously, especially if someone's goal is to have children, that's not preferred. And depending on how young a person is, they may label it as premature ovarian failure because we're not expecting that to happen until at least the 40s. However, I do have some patients who are in their late 30s and starting to notice some of those changes as well. And unfortunately, like I said, there are those who are even younger than that. So in their 20s, early 30s. So it does happen. Less common. It's not the most frequent thing, but can happen. And so in terms of symptoms of estrogen deficiency, funny that. That looks kind of similar to what we talked about before. So we've got cold hands and feet, fatigue, foggy thinking, changes in temperature, headaches, irregular menstrual periods, decreased sex drive. All these things look very, very similar, look very familiar. We talked about this a little bit already. The textbook or medical definition is actually that 12-month. That's actually what menopause is. Everything else around it technically isn't menopause, which is kind of confusing, but that's really what we're talking about. So it's either peri, if we're still leading up to that 12-month straight 12 months, consecutive 12 months, without a moon time or a period. The other thing too, if you are officially postmenopausal and you notice any bleeding that doesn't make sense. So let's say if, for example, um, you did happen to trying to think of an example, to be honest. But if you do notice bleeding, that's a little bit more, even spotting, I would say actually, it needs to be assessed by your doctor because once you are postmenopausal, we shouldn't see any bleeding at all. And so that's really important to get that checked out. And knock on wood, I'm very grateful to say that I haven't seen this too much in my practice, but I've had two patients who did tell me this. We got them checked out. Thankfully, we caught it early, but both of them did have early stages, early changes of cancer. Okay, so that's what it can potentially be. That's why we want to get checked out. Both of them are fine. We caught it nice and early. We were able to deal with it, well, their doctor, because they had to refer them on for cancer treatment. But they're both doing well. So this is one of those things we don't want to ignore it. We don't want to leave it alone, okay? A lot of people will ask, do I need testing? Do I need to go and get labs done to confirm if I'm perimenopausal or going into menopause? Technically, we don't need to because your hormones change a lot from day to day. So it's not a case of where we can't test them, we can. It's simply a case of often symptoms are enough. So it's not a case of your doctors trying to be mean and withhold testing all the time. Sometimes they're being a little difficult, but sometimes it's not really a case of we need to. So they may order estrogen, they may order FSH, they might even order a fuller hormone panel. But it's not always the case that we absolutely need that to help to support you, right? If you really want to do the testing, it's doable. 100% it is doable. But it's more just the case that you don't always need to do it. That's really the thing. Unless you're starting to get into conversations about hormone replacement therapy and that kind of thing, that's a bit of a different piece in conversation, right? And then, as I said, often this one doesn't always get talked about as much, especially if you've had thyroid issues previously, like already pre-diagnosed. You might just want to get it tested again just to make sure that your medication is still actually helping to support, because I've seen that happen a few times where your needs actually change because things are changing, right? So sometimes that's a good time to talk to your doctor about retesting if it hasn't been tested in a little bit. Or if we're starting to notice other symptoms that are kind of sounding a little bit like thyroid problems, then sometimes we want to look at that in more depth too. Because if you haven't been diagnosed previously, not to say everybody has thyroid issues, but the three times that we're most likely to have a new diagnosis is when we have a big change or fluctuation in our hormones. So that's when our moon time starts, if we have children. And that's with each pregnancy. So anytime I'm working with my pregnant patients, I tell them within that first year, we want to recheck your thyroid to make sure everything's okay. Because if you've developed a thyroid condition since, we want to step in and do something about it. And then perimenopause, menopause, right? Other piece of the puzzle that I feel like we don't really have enough conversation about is our heart, right? So if you think about it, for the most part, statistically speaking, how many women under the age of 50 do you know that have had a heart attack, right? Part of that reason is the protective role that estrogen plays, right? So unfortunately, because of that decrease in estrogen, we do see a moderate to semi-significant risk of heart disease increase when we're heading into perimenopause and menopause. And our it's not too different. I know that's from 2011, that stat there, but I checked the other day and it's almost the exact same number. About every 7 minutes in Canada, someone dies from heart disease or stroke, right? Two of the three leading causes of death is heart disease and stroke, right? They haven't changed too much, sadly. So we want to be talking about our heart health just as much as any of the other pieces. Not to like, and as I said before, I'm not trying to underplay or downplay the pieces in terms of the hormones and helping to support the hormones. But this is part of it, right? So this is a essentially a side effect, if we want to frame it from that perspective, of seeing the estrogen decline, which is one of the main physiological changes that's happening when we're going through perimenopause and menopause. So, when we're talking about cardiovascular disease, that's basically the entire cardiovascular system. So that's the heart, the blood vessels of the heart, the arteries and veins that travel throughout the rest of the body and in the brain. And then stroke is when we have a blood flow problem specifically in the brain. So that's more to do with stroke. Because sometimes people are like, well, what's the difference? I hear them say heart attack and stroke, but it's like, aren't they kind of the same thing? They are quite similar, but they're not exactly the same thing. So, so how can I tell if someone has having a heart attack? The other reason I like to talk about this too is because, generally speaking, for women, and for those who do, we're I always say this part too is like if it's someone who's technically transitioned, so let's say an individual who was born biologically male and transitioned to being female, so therefore have gone through hormone replacement therapy for that purpose. I don't, at least I have yet to come across. I may need to do that deep dive again. I don't actually know what the impact is. If you start to match similar numbers, because it's your hormones are so closely titrated, right? And it's that case of where we're constantly monitoring them, or relatively speaking, compared to individuals who have um been born female, and for the most part have maintained their female reproductive and sexual characteristics, right? It's someone asked me that recently. I was like, you know what? I don't know. So just so that I didn't want to forget to mention that. But just because that's the case doesn't mean that it's wildly different when we're talking about potential signs and symptoms of watching out for somebody if they're having a heart attack, right? So yes, we can have that classic pain in the chest, pain in the arm. But the other thing that's a little bit more common is actually the jaw. So having jaw and neck pain, right? Again, it's not to say that you won't have chest pain, but it's the case of where, unfortunately, what happens with a lot of women or those who fit in that category, is that they'll ignore some of these other things like the stomach pain. It's like, oh, it's just a little bit of heartburn, or the shortness of breath, or feeling that impending sense of doom when that's not something you typically feel, right? Lightheadedness, sweating, nausea, vomiting, those are some of the more common, like overall common. But I like to just touch on that briefly because I would say that's one that a lot of people don't necessarily think about, is if I'm having, you know, semi-unexplained or out of the blue jaw pain, right? They can often be subtle. It's not always, you see in the TV shows or the movies, it's like someone grabs at their chest and then they're falling on the floor, right? Yes, that does happen. But it can also be very subtle. Um, it was like I wasn't there when it happened, but my grandfather experienced a stroke. And thankfully my uncle was there at the time because he was the one to notice that my grandfather just kind of walked into the family room, sat down in a chair, and didn't look so good. He wasn't saying anything. He didn't want to be a bother. And it was my uncle who picked up on it. He said, "Are you okay?" And my grandfather couldn't speak. He was speaking in slur, right? So, and then he went gray. And thankfully, my uncle called 911 in time and they got him to the hospital in time. But had he not noticed that he kind of ran away from my grandmother and my uncle, we might have lost him that day. So sometimes it's not that drastic. I'm going to fall on the floor, right? So, and don't be tempted to downplay your symptoms. Don't brush them off, right? Pay attention. Worst case scenario, you go to the hospital, they hook you up. Yeah, you're fine, you know? And then you're still here, right? So, I just, again, not trying to fearmonger or hammer on this too hard, but it's important, right? Don't tough it out. It takes a few minutes. That's what emergency services is there for. And please don't drive yourself. Please, please, please. I get it. You don't want to be a bother. The hospital's nearby, whatever the case may be. But again, if you're on your own and you have no other options, of course, but like absolute last resort, right? We have no other options left. We can't knock on the neighbor's door. We can't get a hold of anybody. We can't call 911. That's a pretty remote situation if we're having to drive ourselves there. Um, so yeah, and just again, um, yeah, just trying to be um, good on top of that sort of thing. And of course, like I said, I don't want to be all doom and gloom because that's not the point. So we want to talk about some things that we can help with, right? One of those central tenets of naturopathic medicine is principles of healthy living and preventative medicine. So that means we want to help prevent things before they happen. So we can utilize a lot of tools actually to help us to achieve optimal health, right? So things that we often talk about from a hormone balancing standpoint, although it actually applies in a lot of standpoints when we look at the research, is more of a Mediterranean style diet. So the only, not to say, obviously, some of our traditional diets were also extremely healthy, but the standard North American diet, not so much, right? So we want to get away from those deep fried foods, those highly processed foods, the things that I tend to refer to as Franken foods, meaning that they're highly processed. It's like, well, I'm going to jam like 12, 15, 20 different ingredients together. Half of them are as long as my arm in terms of letters, and I can't really pronounce them. And look, it looks like a bar. And it has no sugar and no carbohydrates in it. And, whatever other fad things they're trying to kind of hook into. No trans fats and peanut free, even though there's no peanuts in it anyway, or anywhere near it. So those are the things I tend to refer to as Franken foods. They're not real food. We're meant to eat real food. That's what Creator gave us. That's our original instructions. It's fruits and vegetables, it's protein, it's healthy fats, it's antioxidant rich foods, right? That is really what we're talking about here. Getting enough fiber, because so many of us, like across the board, not just talking about those of us who are women and identify as women. It's men and women, all people. We typically do not get enough fiber based on the population level studies that we do. We're not getting enough. So we really need to, well, overall healthy diet, but definitely fiber. Fiber, we tend to do a really bad job. And protein. Protein's another one we tend to not do so great with. Phytoestrogens. So this particular group of foods is plant estrogens. So they actually produce a particular molecule, the phytoestrogens, which the body recognizes almost the same as estrogen. So they're generally helpful foods to help to bolster our estrogen levels a little bit. We don't want to go too overboard with them. So sometimes people will say like, oh, what about soy milk? What about tofu? What about some of these soy products? It's, again, in the right amount, like anything else. If we overdo anything, not so good. If we're getting a decent amount, then that could actually be helpful, right? Berries, flax seeds, sesame seeds, garlic, cruciferous vegetables. There's a good amount of phytoestrogens out there that we can potentially be incorporating in the right amounts into our diet. Lifestyle. So that is moving our body. We really, really, and this is true, really, unfortunately, across the board, but especially as we're getting into this stage of life. Because what happens is once we hit about 30, actually, and especially past 35, is that for every year, we're losing a little bit more muscle mass. And that's just like day-to-day living. That's not even a case of like, do you actually do exercise or do you not exercise? That is just baseline. So then times that by decades, every decade, if we're not doing things to help to promote muscle and to maintain muscle mass, we're going to continue to lose it, right? And it's such a vital, vital, vital thing to continue to protect and to promote and to continue to try and build, right? So it's yes, of course, there's a lot of concern around weight and weight maintenance. But it's as much of the as that is part of the conversation, it's actually that weight bearing slash strength training type exercise. I'm not saying that cardio is not important. It is still important going for walks, long or slightly brisker walk or running, whatever works for your body, right? Because I myself am not the biggest fan of the gym. I don't tend to go to the gym consistently, so I do other things. I like to find other activities outside of going to the gym. Not to say there's anything wrong with going to the gym. If you're the type of person that enjoys the gym, that's great. Go. Go do what you need to do. It's just that typically the people I talk to are the ones that are scared to go to the gym for all kinds of different reasons. I won't get into all of them right now, but it's just not their comfortable place. So it's like, okay, then what are the things that we can do to help you to achieve those goals, even though you're not going to the gym to do them, right? So those, it's so important, so, so, so important. Detoxifying your liver. So again, liver is constantly processing everything, including your hormones. So if we're not doing enough work to support it, that's another thing that can kind of lead to some of the symptomatic experiences that we have of perimenopause and menopause, and of course, stress. Almost all of us tend to underestimate how much stress we're under, especially as women and caregivers and those of us who fall into those types of roles, however you identify. And we need to be moderating your stress because that is absolutely adding to all of this. Because if your cortisol levels stay high, then I can almost guarantee you, to be honest, if we're not dealing with stress, that's going to add on top of everything else, right? So this is not meant to be an exhaustive list. This is just mentioning some of those important nutrients that technically are almost always important, but they become a little bit more important as we get closer and closer, or if we're in to that transitional phase, right? So we have magnesium. Actually has an important role to play in all the muscles. So every time a muscle contracts and then relaxes, a big component of that relaxation phase of the muscle is magnesium. And we know from lots of studies now that on a population level, we're about half to sometimes even closer to like 70 plus percent, depending on where we're talking about, deficient or significantly deficient in magnesium. That's partly because of our farming practices. So our food isn't as rich in magnesium. Therefore, we have to consume more food to get the same amount of magnesium that we got 40, 50, 60, 70 years ago. So it is partly a farming practice problem, but it's also, again, so that it just carries down the line, right? So it is unfortunately one of those ones I tend to notice we need to supplement with more often. Um, Simply because it's not as easy to get enough from our food. CoQ10, again, really, really important for lots of cell function. So like almost every single cell needs CoQ10, but it's definitely one of the ones we talk a lot about a lot for the heart. So anyone who's taking a statin in particular, so that statin medication, so that could be rosuvastatin, any of the other statins. Unfortunately, what happens is the body gets depleted in CoQ10 when we take a statin drug. So it's a really important one to potentially consider, talk to your doctor, talk to your naturopath, make sure you're taking the right amount for what you need if you need it. Not saying everybody needs it right away, but especially if you're talking, especially statins. And I'd say at this point, it's very rare that I ask a patient, "Oh, I noticed you're taking a statin. Did your doctor have a conversation with you about CoQ10?" And they're like, "What the heck is CoQ10?" Okay, answered, and this is what we're going to ha now have a conversation about in terms of CoQ10. Carnitine, really important for energy production and helping to keep the cardiovascular muscles healthy. So we sometimes also will see it used for mood and helping with mood as well, but a little bit more so on the cardiac side of things. And then, of course, calcium and vitamin D, always, always important. Vitamins, but especially as we get older, if we don't have enough, if we haven't deposited enough into our bones as it stands right now. And that's another big one for weight-bearing exercise or strength training, is that stress, that moderate stress, not humongous stress, but moderate stress that exercise provides actually helps to reduce the risk of osteoporosis and osteopenia as well. So essentially having weak bones, bones that can break, unfortunately. We are not going to cover every single one. You will get a copy of the notes if you so desire it. It's just to give you an idea of how many different options are out there when we're looking at our plant kin, right? So there's lots of different herbs that we have that can assist us with hormonal balance issues. So again, I'm not going to get into all of them. It's just to show you how many are out there. I would say some of the ones that I tend to use a lot are kind of that top three, four there. So the Vitex, the black and blue cohosh, and the red clover. Again, not to say the other ones don't also get used in the mix there, but I would say these are some of our bigger herbs that we tend to use a lot more often. Now, note with the St. John's wort, if you are currently taking any other medications, you're going to want to have a conversation with your doctor about that, because unfortunately, one of the drawbacks with St. John's wort is that it interacts with pretty much every single medication on the planet. So typically, if you're taking a med, either we can't use St. John's wort or we have to use it in a different way. But there's lots of other options that we can use outside of St. John's wort. It's just an unfortunate side effect that it has to basically be used by itself, or there's a decent amount of our plant slash nutraceuticals we can still use with St. John's wort. It's just the medications, unfortunately, do not do well because it either increases so it stays in your body longer or it processes it out faster, depending on the medication. So that's why we typically can't use St. John's wort a lot of the time. So black cohosh helps with balancing hormones, thought to be also a phytoestrogen, generally helpful for hot flashes and night sweats, generally mild, sometimes none, hopefully, in terms of side effects or contraindications. But I would say if they do happen, it tends to be digestive upset, skin irritation, maybe a little bit breast tenderness. Sometimes we do have to be a little careful if someone has been treated for estrogen dominant breast cancer. Damiana, additionally, also has some really positive impacts for mood and nervousness. I would say it's one of the herbs we don't tend to use as much in terms of like overall general use. There's not, I would say, if you ask someone if they've heard of Damiana, probably not, unless they happen to have a bit more of an herbal background. But generally used to help with vaginal dryness. Again, generally low side effects when used appropriately. It's usually not until we're starting to use higher doses that we can potentially see some issues there. Motherwort. I actually really like motherwort personally. I like to combine it with some of those other herbs, partly because of this its heart and stress effects. So it's known as a cardiac tonic, meaning it's generally beneficial for the heart and the cardiovascular system. But then it also has some really great general stress relief and calming effects for the nervous system. Also tend to see some good impacts for hot flashes and mood fluctuations. Sometimes do see some GI upset with it in higher doses, but actually in the right amount may actually help a little bit with mild GI upset. So it's usually not until we get into the higher doses. But again, like anything else, you want to be careful with how you're combining these things with your medications in particular, right? Ladies' mantle, especially if we're noticing heavy flow, extremely painful periods, we might want to consider ladies' mantle, hot flashes, night sweats, some of those very classical symptoms of perimenopause can be helpful with. Sometimes also helps a bit with diarrhea because it does have tannins in it, and then it's also protective for the liver. And again, generally low risk of side effects when we use it properly. It's usually if it's in too high of an amount or if we're combining it with medications that it shouldn't be combined with. Possible liver damage concerns, I have a asterisk there because that was more to do with like a singular study, and the methodology for that study wasn't very well put together. Again, we're still, using it appropriately and carefully and all those kinds of things. But what we actually think is that the risk of liver damage when it's used appropriately is actually quite low, and that's not really a main concern. Peppermint, most of us know peppermint for indigestion, for bloating, for nausea, but it can also be helpful for mild pain. So sometimes it can actually help to reduce some of the discomfort because it's helping to relax. And generally low side effects unless you have sensitivity to peppermint slash the mint family. Or if you happen, some people that do have acid reflux or hiatus hernia, it does seem to trigger that a little bit for them, but not for everybody. Um, and again, generally low risk, low side effects when we use it in appropriate amounts. And of course, being careful with certain medications in that regard. The hemolytic anemia, again, not really a huge concern with peppermint unless you are consuming a lot of peppermint. And then, of course, if you're actually dealing with anemia yourself. We talked about St. John's wort already in terms of that concern with almost all the medications, really, unfortunately. But if we can use it, it does have some really great effects for helping with mood, can be comparable to some SSRIs in terms of impact, but less side effects than your typical SSRI medications, and can also be helpful for um, especially for seeing like lower sex drive. And it's also antibacterial and anti-inflammatory, which is pretty great. And yeah, like I said, unfortunately, there are certain categories of individuals if they have severe health concerns, like severely immunocompromised, sometimes diabetics, but not always. And then again, like a lot of things, we just want to make sure we're having appropriate conversations with the right people about things before we start them, right? White sage, also helpful for balancing hormones, also thought to have phytoestrogenic properties and helping with hot flashes and night sweats. And sometimes we also use it as a respiratory herb as well. Generally mild, if any side effects as well. Again, maybe some potential concerns with estrogen dominant breast cancer. As a naturopath, I will use homeopathics. So, homeopathics would be, they generally speaking, they do come in other forms, but they're little white pellets that we put under the tongue and let them dissolve. So there's all kinds of different homeopathic remedies that sometimes we'll use from a naturopathic perspective in combination with these other things if it's appropriate. And of course, like most things, we want to talk to a naturopathic doctor, homeopath who's or a homeopath who is well versed in the remedies and how to use them properly. I do acupuncture in my practice, so I do mention it briefly because it is something that we'll use from a Chinese medicine perspective to help to balance the hormones. So when we're talking about it from that perspective, we're talking about liver and kidney dysfunction in the sense of they talk about it from the perspective of the qi not flowing well or the qi being blocked. Right. So part of what we're doing with acupuncture and a lot of these other things actually is we're trying to reestablish a good flow of chi, but then also a good flow of all the other fluids and mechanisms of the body, right? And so we know both from a Western physiological perspective and an Asian medicine perspective that the liver has a lot of really important jobs to do in terms of filtering out toxins and keeping things moving well. So we want to make sure that that stays balanced and that we're supporting that well. All right, so that's all the material that I had for today.
Thank you so much. We have so many questions.
Yes, I kind
I'm
of saw,
going
I was
to
like,
just get,
yeah,
yeah, I'm just going to get right to it, and
yep,
then we can hopefully power through a lot of these. So
okay.
there was quite a few questions around hysterectomies
Mm,
and if cervix was removed or if ovaries were removed, whether that be due to cancer related or PCOS or any other related um,
hmm
uh, like sorry, I'm trying to think of the right word. Any other related things that are going on in your like pelvic area? Um, what sort of would that impact menopause and like what would that
hmm
look like in what
Yeah,
you've seen?
yeah, absolutely. So, for the most part, if we have a hysterectomy, then we're generally considered to be in menopause um from a hormonal standpoint, right? It's becoming much, much more common now that they try to save as much as they can. So it used to be the case where they like, nope, just take everything out, just take it out, just get it out. But they're starting to realize that that's not necessarily always the best thing to do. In all cases, obviously, case by case basis, like you said, like could be cancer, could be lots of other reasons why we're looking at hysterectomy as being a part of good care, right? So, generally speaking, from what I've learned, again, I'm not a surgeon, I'm not a medical doctor or gynecologist. So, again, just take that with a little bit of grain of salt. But from working with people who are going through that process and then have had it and then are and ultimately coming to me, is that they do seem to be really trying to save the ovaries if that's again safe and possible, even if it's just one, because what they notice is that that makes a big difference, right? Because the longer that we're in that perimenopausal, menopausal, postmenopausal state, is that means our estrogen's already declining, right? And so we have a longer potential period of time that our body's being impacted by lower than optimal estrogen levels, right? So those are the individuals that we're definitely going to want to have a conversation about what can I do in addition to hopefully saving, again, if that's appropriate and all those kinds of things, then can we save it? And if not, what are the other things that we can do to help to support me so that I'm not seeing those impacts as soon, right? So that's usually where the conversation is now starting to go a little bit more reliably, which is a good thing. Really, really good thing. Yeah.
And that can happen at any age. So if you had
hmm
to have that like in your early 20s or even younger,
Yeah.
potentially, hopefully not, but
Hopefully not,
that could
but
happen then. So
yeah.
um so just I think being mindful for other older individuals to have empathy for all
hmm
individuals because we don't know their background, right?
Yeah,
Cool.
absolutely.
Um, our next question is regarding hormone replacement therapy. So, um, one overarching question was kind of what is there a relationship between estrogen, progesterone dropping with testosterone? And has
Hmm.
there been any links with hormone replacement therapy with cancer? I know we kind of talked about how there was a little bit of stigma at the beginning because of the lack of research.
Hmm.
Do you know if that's kind of shifted or whatnot since you've started your practice and whatnot? And
Hmm.
is there certain hormone replacement therapies that are better? So, like if topical or the
Hmm.
medication one where you consume it
Yeah.
orally, what are your thoughts?
Yeah, yeah, absolutely. So, and actually, I just know someone did mention, which is it's exactly that, Angie, is that standards of care are shifting, and so we're trying as best as possible to preserve function where we can, and obviously, like you said, yes, of course, if there's a higher risk of cancer there, then yes, no, we're not. They're not going to look at leaving that tissue behind. But as far as the like the HRT itself, so I have seen that shift even just in the last couple years because what ended up happening is we had um the I'm going to mess up the name of the study now, but it was the I believe he was the Women's Health Initiative, I believe was the name of the study. But anyway, it was one of the big landmark studies that they did. And what the outcome of that study was this big kind of like, oh gosh, don't do hormone replacement therapy because hormone replacement therapy is dangerous. Because a lot of the results that they were getting back, they actually had to shut the study down early. They didn't actually complete it because they were getting enough numbers back saying increased risk for certain types of cancer, increased risk for, I believe, is heart disease in general. So basically, just bad things. That's what was coming back from this study. And so that colored our perspective of hormone replacement therapy as a whole for over a decade. It's actually getting closer to more like 15 years now. And so a lot of practitioners are nervous or scared about HRT as a general thing because of that study. But what we're actually finding with more recent studies is that's not the case because what happened was a few problems. There was a few methodological problems, but one of the big ones was the type of HRT they were using at the time. So it was actually a derivative of, if you can believe it, of all things, horse urine was one of the main derivatives that they were using at the time. And the other thing that we've learned since then is you have to be a little more careful about how you're applying the hormones. So we can't just give you estrogen. It's like, here's a whole pile of estrogen, 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 estrogen. We can't necessarily do that. We may have to balance it out actually between estrogen and progesterone because we always have testosterone. All of us have testosterone. And those who present physiologically male, they also have estrogen and progesterone too. It's just simply the amounts that we have them in. So obviously, if we're presenting physiologically as a female, we have more estrogen and progesterone than we do testosterone. But presenting as a physiological male, then those ratios are more or less flipped. So technically, men, because their testosterone drops as they get older, they also go through their own version as well. Sorry, I'm just gonna grab a sip of water here.
It's so interesting how we let a sample size, I like kind of make way for the rest of the world and kind of proves
Hmm.
that we need to do more research within women and female reproductive health
Hmm.
more so than what we've
Yeah,
been doing. So
yeah,
definitely.
yeah,
Um,
absolutely.
and the next question is, how did you find ENDO and PCOS affect women when they start perimenopause?
Yeah, definitely an excellent question as well. So it is a case where we do, unfortunately, see a little bit more of an impact. So what I've noticed in practice is sometimes it's not a direct correlation. We don't have enough data to say this reliably yet, but sometimes I do notice that they are going into it a little bit earlier. And then what we also see is sometimes, again, not always, we don't have a direct correlation at this point that I've been able to uncover anyway, is that sometimes the symptoms are a little bit more pronounced. But just because we're living with those things, doesn't necessarily mean that's also always the case. And the other thing too, actually, is sometimes it's actually a case of relief because if part of why your symptoms are as they are with living with PCOS or endo or both, sadly, if you're one of those poor individuals who really got the short end of the stick there, um, we actually do sometimes see that you get some relief from some of those symptoms from PCOS and endo. And then sometimes you actually don't have as many symptoms perimenopausally, or at least it's almost more of a case of like it doesn't seem as bad for you because you've kind of some of it you've already been dealing with, if that makes sense. Whereas others who aren't dealing with PCOS or endo, and they're heading into that stage of life, it's all new, right? So, it's I know it's not necessarily a a really straightforward answer, which sadly we hardly ever get when we're talking about PCOS and endo, but it's not always a case of it being worse. It's more just a case of sometimes it is. Yeah.
And have you ever noticed anything that like perimenopause or menopause has ever interacted with mental health diagnoses like bipolar, BPD, schizophrenia, or any of the following that might have
In
already listed?
terms in terms of like those
Whether
like getting
whether that
worse.
be like a manic episode or psychosis. Yeah, like would perimenopause kind of impact both or menopause have interacted with any mental health diagnoses?
I don't, well, so it's a bit of both. So what I'll say is, when you've already been living, especially for those who have, which is usually the case, you've been living with that condition for some time. So you've already been either managing it or hopefully managing it, or getting some assistance with management of it. There can sometimes be, because again, you're going through another big change, right? And one of the hallmarks of that change is changes in your mood. So I have seen that where sometimes either um, people will notice, like, it's like, I'm not feeling quite myself. So that's usually when we'll say, okay, like maybe it's a time to have, if it's been a while since we've done a review of our medications and our medication doses, it's maybe a time to do that, right? Because yeah, it can be, more of a mild, kind of like I just don't quite feel like myself. I'm feeling kind of low, to something more significant. Like I think I did see that someone mentioned, um, it could get as strong as suicidal ideation. Absolutely. So that can happen, right? It's whether it's depression or, and I don't mean to sound dismissive by any means. And that's why we talk about those things. That's why I love the fact that I get to spend more than 5 or 10 minutes with patients, because then I ask them like, how are you doing? And if you're a busy person who's also providing caregiving for children, aging parents, you're caring for everybody, like especially those of us who kind of fall into those kind of roles, it's sometimes been a long time since someone's actually looked you in the eye and said, how are you actually doing? Like, I want you to actually tell me how you're doing. Don't just say, "Oh yeah, I'm okay. Yeah, no, fine, fine, fine. See you later." All smiles, fake smiles, right? So it's yeah, these are really important conversations to be having and checking in with our friends, checking in with our loved ones. Like, are you doing okay? Do you need some help? Do you need some support? Right? And for those of you like I really want to the fact that you're feeling comfortable enough in this space to mention that you've experienced these things, I want to commend you on that because you are helping all the other people who are in this space right now by saying, "Hey, this happened to me. It could happen to somebody else." And that really helps us to know how important this conversation is and the fact that we need to be having it more and that we need to be checking in on each other, right? And don't I would encourage you, I know it's not an easy thing to do, but don't be afraid to say, "Hey, I need some help," right? So, yeah.
Definitely. Yeah. With that, we kind of talked about how culture has that you mentioned a few stories that you've heard over the course of your practice and within as a naturopath. Do you find that there's any other rite of passage groups or community companies um, kind of honor women who are entering that new phase of life or individuals who are entering that new phase of life? Um, just so that we kind of embrace that community and honor our individuals who are in that new stage, right?
Yeah, that's one area I would say, at least from what I've seen, is we're just kind of starting, right? So when I was initially putting this kind of presentation together for another community I was working with at the time, I was like, what do we have? You know, and I went, you know, digging for stuff. And there are more resources. Like I would say every single time I go to do that search there's more resources popping up like um that web series I was talking about, the menopause web series. There's more of that coming out now, which is so encouraging to see, but it's been very lacking, I would say, up till now, at least of what I've come across. I'm not trying to say I'm the absolute end of the world authority on it. I think we do still have a lot of work to do, though, collectively in terms of like it should be pretty easy. Just like I can go say, Where's my nearest friendship center? Where's my nearest, learning center?" All those kinds of resources that are out there now, right? And we have women's circles. Thank you so much for pulling that link up there, Sherry. That's really helpful. If you're looking for that link, Sherry just threw it in the chat there for you, everybody, just in case you were looking for it. And it's really just like chatting. It's like, sitting down. It's the grandmothers, the Moon Lodge sitting and chatting. It's really what it is. And it's a great resource though. I had it on in the background and I'm listening and, doing a few other things at the same time. But yeah, I think that's what we really need to expand on, to be honest. Because as much as there's like, and I don't mean to sound exclusive or excluding when I say there's women's groups, right? There's women's circles and different things like that. But I don't think there's enough yet where we're talking about this, that we're talking about perimenopause, menopause, postmenopause, and then also supporting each other and our communities more wholly in a good way. I think that part we still have quite a bit of work to do. Yeah.
Definitely. And destigmatizing kind of like shifting away from like that uh patriarchy and misogyny around um female presenting health and want, kind of being more open. We are also needing this support. So we talked about the different uh, vitamins that you were recommending. Some questions were, what type of magnesium are you referring? Like, are you talking about all magnesiums? And would the is it COQ10 supplement also be recommended for both women and men.
Hmm.
And when wanting to try some of these herbs that you mentioned, is it best to just go to a naturopath to ensure that you're on the right path with this? Or do you think even just testing some ones that you already know that work with your body, like mint tea or whatnot?
Mhm.
What are your thoughts?
Yeah, absolutely. So, it's a possibility, like, and so, and it's, I guess someone or a couple pointed out rightly, is there are different types of magnesium. I would say probably the more common one we would be talking about is the magnesium bisglycinate. But it's not to say that the other forms of magnesium don't enter into the conversation as well. And sometimes it's even the combination of a couple different forms that ultimately end up being the most beneficial. So it ends up being a bit more of a case by case basis if we're looking at a specific form or possibly combining a couple different forms of magnesium together. But in terms of just like our magnesium stores in our body from a population-based standpoint, study-wise, we're definitely, quite generally quite deficient. And so that's part of the reason why we bring it up. And there's lots of other, like there's so many different enzymatic reactions in the body. I believe it's over, I want to say like 300, from the last time I did some of the reading on it, that magnesium has a role to play in the body. So that's a lot of places where magnesium is important. And then as far as the CoQ10, yes, that would be applicable to both men and women. So if you're taking a statin, irregardless of your physiology, I'll say, that's what happens. So I talk about that with all my patients. If statins are part of that piece. And then as far as I, especially in this kind of format, because I'm not getting a chance to talk to you directly one-on-one. Um, that's where I have to say, like it's always going to be my recommendation to talk to a naturopath, talk to a traditional healer, talk to your healthcare provider, or connect with one if you don't have one yet, to help you with that. Because yes, like I said, and that's part of the reason why I focus on those ones is that generally they are lower side effect herbs and things like that. But just because something's lower side effects doesn't mean you won't have side effects. And if you're experimenting with a lot of things on your own and you do have something come up, who do you turn to? Right? So I only say that and out of my, it's honestly out of your best interest is why I say that. Because then if you're working with someone who knows how to combine these things well, it's actually going to help you get there faster because sometimes, and I've definitely heard this said sometimes is, well, I'll try a couple things and just see how it goes. And if you don't really know what you're doing, you can actually end up spending more money and wasting time and as well as money trying to figure this all out on your own. And then you've got 5, 10 different bottles in your cupboard that you don't really know what you're doing with them, how they're interacting, what they're doing. And you just kind of end up getting a little bit or a lot confused. Whereas you could have just gone and seen a naturopath and they could have put together a treatment plan for you and gotten you off on a good track, hopefully quicker than if you're trying to figure it out all on your own. So I'll almost always say it's generally speaking in your best interest to work with someone who knows what they're doing. So yeah.
Yeah. And, and with that, any of our viewers who are in BC who have a status card, I believe FNHA covers a lot of go to on FNHA's page. You just have to let your pharmacist know, and you can get, I believe it's like vitamin D, I'm assuming calcium and all that stuff. So if you have a status card and you're in BC, definitely talk to your pharmacist about that. Just so you don't have to invest as much into all of those that are already covered with our Plan W. Um,
Yeah.
one thing that I learned recently. Um,
Hmm.
on the
Which
topic
I will
of
say, you guys are
fitness,
very
you
lucky.
kind of talked about strength training.
Hmm.
We have Yeah, and then we have another question, like building on top of that. So we were talking about a little bit of like pelvic floor health and like if you are in menopause, are you more likely to have a prolapsed cervix? And what are your thoughts on like how many times should we strength train? What type of strength training? And is there any way to set up for some of our younger viewers who are just trying to be mindful of how to
Hmm.
support themselves to going into perimenopause and whatnot, of like pelvic floor health and whatnot.
Yeah, absolutely. So as far as I'm aware to date, there isn't any, at least we don't have any, we don't have enough, or it hasn't been collected data to suggest that you're more likely to have cervical prolapse or any other kind of prolapse as you get older. It's other things that actually put you more at risk for potential prolapse. So part of that actually is weakness. So weakness of the pelvic floor in general. So if you're at all concerned about prolapse or anything like that, that's where you may want to connect with a pelvic floor physio because that's what they focus on, right? So they can really assess the pelvic floor well. And if they are seeing, either risk of prolapse or an actual prolapse, they can give you exercises to help you to rebuild the strength and hopefully reverse the prolapse. So it's not always the case that you absolutely need surgery to reverse a prolapse. The other thing too is in terms of exercise, again, depending on where you're starting, it's almost always a good idea to start low and then work your way up, especially if you're someone who hasn't really, I've heard lifting weights or doing something new, or something we haven't done in, a really long time. It's almost always a good idea to either, whether it's to go to a class or if you have the resources to connect with a trainer or a kinesiologist or a physiotherapist. That might not be a bad place to start, because then they can guide you in terms of getting into your fitness routine in a way that's less likely to cause injury, right? So that could potentially be one solution, depending, again, I know sometimes it's also a question of the resources we have access to and everything like that. But also there's also some really good resources, even just sometimes I'll say to people like, I know it sounds really simple, but um especially for just getting back into activity, being compassionate with ourselves and going slow and just really seeing how our body responds. Sometimes some of those beginner exercise videos online, like on YouTube, which are free, some of them are pretty good actually. So sometimes checking those out, and then of course always listening to your body. Like if your body's saying, yeah, I don't like that, then maybe that's not right for us just yet. And if it's persistent, get it checked out. Like, is maybe you have a hiatal hernia that you don't know about because it's actually a little bit more common than most people think. I know my grandmother was one of those people that it took a really long time before she actually got diagnosed with hers because she was just like, it's just part of getting older. It's like, is it though? So I mean, again, generally, especially in her case, thank goodness, is pretty mild. So it's just one of those things she had to kind of figure out how to work with, and that sort of thing. But yeah, there's lots of different resources online nowadays. I mean, always, vet your sources and check them out and make sure they are a reliable source. Um, or if you have a friend like, hey, do you know someone or do you have a really good resource? Like that's where connecting with our community can be really helpful as well. So, yeah.
And I believe a lot of our youth are doing physiotherapy school,
Yeah.
kinesiology, and even just throwing it out to a band meeting or community meeting and saying like, hey, if you're wanting some more hours and wanting to support a community member, I think that's a great way to build relationships within community and then also um, work together and whatnot.
Hmm. Yeah.
Um, that will be our last question. We had so much more, but we're at our time. So I'd love to let you say some parting words before we end this webinar.
Yeah, I just want to say miigwech, nyawa, thank you. It's so great to get to spend this time with all of you and so many wonderful questions and thoughtful questions. I mean, I think I said some very similar things last time I was here, but just you're clearly really thinking about this. And I would, as I kind of said all along, if I can encourage you to do anything, it's to talk to each other. Don't be afraid. If you feel comfortable talking about this, step up and be that person because you don't know who else you're going to impact generally in a positive way. If you're the one that's like, I don't care about talking about this topic, I'll go talk about it all day long. The person who's nervous to talk about it is going to be so appreciative to hear you share what you do know and to start to open up those circles, open up those places where we can talk about this in a more open manner. And then ultimately, ideally, that will lead to supporting each other as well. Because if we're stepping out of the closet and not hiding from it, then we can have proper conversations about it that will actually lead to better quality support and hopefully also better quality solutions, right? So, yeah, I think that's what I'll say about that, in addition to all the other opportunities I had to to share information with you today. But honestly, gratitude and thank you all for being here.
Thank you, Dr. Sarah Connors. I know it's always an amazing discussion having you on the Learning Circle and learning today about perimenopause, menopause, and just some natural ways to support yourself, and even just like a lot of empathy and creating community with this new life stage for individuals. And I think just having some patience with yourself too, and knowing that we have to honor our sacred bodies as they go through a new transition. So thank you. And thank you for everyone for joining us today. We're so happy to have you all interacting with us all in the chat. And yeah, so just before we end this webinar, we'd love to bring your attention to our upcoming webinars. We have Grief and Loss Healing Indigenous Hearts. That's on March 5th from 10 a.m. to 11:30 a.m. Pacific Standard Time. And then we have Leading with Heart and Accountability, an Indigenous approach to trauma-informed leadership. And that is with Decolonize and Rise, who we've had on in the past. And that's also on March 24th from 10 a.m. to 11:30 a.m. Pacific Standard Time. All of our webinars are free to sign up for on our website at learningcircle.ubc.ca. And feel free to sign up for our newsletter. We send all our updates to our newsletter, and you can stay up to date. And yeah, thank you everyone for joining us. We look forward to seeing everyone at our next Learning Circle. Lim Lim, thank you.